Okay, so now we're going to talk about some things we might do differently in assessment. When you're taking a history for a pediatric patient, the parents are going to be historians, but the child also, as they get older, becomes a historian. And sometimes you need to compare those two things because the child's experience of what's going on may be different from the adult's perception of it. Physical assessment, you want to take time and develop a rapport with that child when you can. Use distraction and therapeutic play. Let them play with the stethoscope. Give them a toy one to play with while you do the assessment. We want to just really take our time and allow that child to be more comfortable with this. We start with the least invasive assessments and work to the most invasive. And we usually, for small children, we want to have them start the assessment in the parent's lap and then move to an exam table as needed once they're a little more comfortable. If it's necessary to restrain children for some assessments to be safe, think of a restraint for maybe looking in ears. There are ethical and legal concerns there, so we need to make sure that we're being cautious and following laws, but there's also a debate about whether the parent or caregiver should restrain or another healthcare worker. Some people think that the parents are safer so they can hold the child and make them feel safe. Some people think that it is better psychologically if it's a different person, another stranger instead of the parent. When we are doing assessments, we're going to do some screenings. We do developmental screenings. There are some specific tools developed to help us figure out, is this child on track in different areas of development? We do nutrition screening to get an idea how the child is eating and what their nutritional health is. Vision and hearing acuity are pretty standard in well child visits. And then home safety. We want to screen for dangers specific to that child's developmental stage. For vital signs, temperature, if a child can cooperate, we can do an oral temperature, but we don't do an oral if they can't cooperate. Rectal temp is the most accurate, but it's also invasive, and there's a risk of bowel perforation, especially in infants. So axillary, temporal, and tympanic are the preferred methods of getting a temp. If we need a really accurate temp and need a rectal temp, you need to know how to do that safely. So you're going to approach the child's rectum. You're going to make sure that you're holding the thermometer, not from the back. So we put it in and we have all this space where it can move in and out. We're going to hold it where it's going to be in the child's rectum so that our fingers are up against the child's bottom. Obviously with gloves, because that rectal temp frequently stimulates a bowel movement in littles. Okay, now axillary. When you do an axillary temperature, biggest mistake I see people make is they stick the thermometer in and the tip is sticking out behind the child's arm. So we want the thermometer in so that the tip of it is in the armpit. It's in the axilla. Temporal and tympanic, just make sure that you're following the guidelines of the manufacturer. For tympanic temperature, for small children, we pull a little up and back, adults down and back, and that straightens the ear canal a bit. Pulse, we do an apical pulse for 1 full minute for anyone under 2 years old. Pulse varies with activity. It's highest in infants and it decreases with age. So you need to look at what the normal ranges are for the child's age you're caring for. Respirations, we do 1 full minute respiratory rate, and if the child's under 2 years. You can count respirations by observing abdominal movement, chest movement, auscultation, hold them on your shoulder and listen. Just make sure you're counting for a full minute. It's higher in younger children and varies with activity. Periodic breathing is normal in infants. So when you're doing respirations on an infant, you'll be like, oh, wait, they're not breathing, wait. If it's under 20 seconds, it's considered a normal variation. They just have to really get that breathing thing down in young infants. If it's greater than 20 seconds, it's considered apnea and needs to be reported. For blood pressure, make sure the cuff size is appropriate. You know how to check cuff size. That applies to children as well. Blood pressure can create fear and it can be tight enough to pinch. So unless there's a reason we're concerned about blood pressure, we don't always do blood pressures in small children. For growth measurement, for height and length, under 24 months, they need to be lying down. They need to be measured on a board or on a firm surface with a board at the head. So their head is firmly at the head of that table. Extend the heel all the way out and measure to the heel. After 24 months, they need to be standing in bare feet. Weight, they need to either be lying or sitting in an infant scale until they're able to stand on a scale. Make sure that you keep a hand very, very near them when they're in that infant scale. Don't get too far away. Head circumference, we measure just above the brows and the pinna. Okay. Tanner scale, sometimes they're going to look at the Tanner scale in like middle childhood to see if that child is approaching puberty. It's based on secondary and primary sex characteristics. Be very cautious when examining secondary sex characteristics and genitals. Make sure that a parent is present. Warn the child that you're going to look and touch them, and make sure that they give them the opportunity to decline that unless it's just really critical. We want to respect that and teach them boundaries and make sure that they understand that we are examining for medical reasons, and that it's not okay for people just to look or touch at their genitals. Okay, in the next section, we're going to talk about medication administration.